Maxey, and I'm one of the 4 co-moderators of the Black Health Trust. We have an exciting program today. Simon, would you unmute Yakini's cell phone? We're going to have an exciting program today, and we're going to talk about health maintenance. So what is health maintenance? Health maintenance is a guiding principle in healthcare that emphasizes health promotion and disease prevention rather than the management of symptoms and illness. It includes a full array of counseling, screening, and other preventative services designed to minimize the risk of premature sickness and death, and to ensure physical, mental, emotional, and health throughout the natural life cycle. The organization of medical care is to encourage health maintenance includes also removing financial, physical, and psychological barriers. Now, most of us as physicians know that health maintenance organizations, even though they mean well, I believe, often get in the way of what diagnostic things you can do. And we have a special guest today that I will introduce. But first, I want to introduce our co-moderators. And my first co-moderator is in an automobile on the way from the alligators of Florida to Tennessee. Dr. Barbara, can you introduce yourself?
It looks like Dr. Barbara is on Yakini's phone and it's still on mute.
Okay. So in the meantime,
Oh,
yes.
There we go.
Go ahead, Dr. Barbara.
Good afternoon, everyone. I am so happy to be able to join with you today in the discussion of this very timely topic. I can tell you that we have a lot of work to do in our community in terms of making sure that we take care of ourselves in the way that we need to be taken care of.
Dr. Walks.
Good afternoon, everyone. Good to be here. I could not agree more with what Dr. Barbara just said.
Dr. Hines.
Hello. I'm a family physician, so this is my wheelhouse. This is my bread and butter. So looking forward to discussing this topic.
Okay. And I'm Randall Maxey. I'm an internist, nephrologist, and currently doing primary care. And I was so interested in this program today, which involved one of my local heroes, that I wanted to make sure that Dr. Hines, who amongst us is a primary care doctor, family practitioner, and she, I think you're the president of the Maryland State Family Practice Association?
So I was, my term is over. Now I am the board chair, so.
Okay, so you're the big boss. So I want to introduce Dr. C. Suzanne Cutter. And of the things that I give her most credit for, she's from the Queen City, God's country of Cincinnati, Ohio. And I don't know why that's so important to me. But she is a graduate of The Ohio State University. She later went to school in Chicago, medical school, but in the interim, she obtained a degree in computer science and was an executive for a computer company for years. And then as another just add-on, she decided to go to medical school. And then she trained at such institutes as Sloan Kettering in New York, one of the #1 cancer institutes in the world, Cedars-Sinai, another good program. And she is now a practicing oncologic surgeon in the city of Los Angeles. and she was recently elected and took office as president of the Charles R. Drew Medical Society. And she has been someone that I have come to look up to in medicine, in business, and as a colleague from the great Midwest city of Cincinnati. And she has agreed to discuss briefly and answer questions that we have on health maintenance. Dr. C. Suzanne Cutter, please join us on the program.
Thank you so much for the warm introduction, Dr. Maxey. Dr. Maxey is a mentor and friend and a great cohort that we discuss business and a variety of things. I'm happy to bring comments. Let me know when the appropriate time is to start, and I'm ready to begin.
Right now. But would you first announce there's a meeting coming up of the Charles R. Drew? Would you just mention that in the subject and then go right into introducing the topic?
Okay, I'm happy to do that. And I actually also have a little slide on that too. So I appreciate that, and we'll do both. But as Dr. Maxey said, I did just begin my presidency with the Charles R. Drew Medical Society, which is the Los Angeles affiliate of the National Medical Association. We would love to have all of you work with us. And we've been successful so far in our first 30 days of getting grants and setting up a variety of programs for medical students and residents. So we'd love to have you involved. Our next meeting is going to be at Fogo de Chão, which is a Brazilian steakhouse in Beverly Hills on March 24th at 7:15. Please contact Don Howard for instructions on how to RSVP. It has to go directly to our sponsor. And from there, we will see you on the 24th with your vaccination card and mask in tow.
Can Dr. Walks come?
Dr. Walsh can come. If you're in town, you can come.
Thank you, Dr. Cutter.
The more, the merrier. I'm going to share my screen now so I can begin my comments, and we can get started. Okay. The last time I spoke on the Black Health Trust, I talked about a blueprint for Black lives where it related to cancer care and the pandemic. So I'm being very optimistic and saying cancer care in the post-pandemic era, right? Because I'm hoping that in the next 6 to 12 months or so, we'll be finished with this. So let's get started. I have no disclosures, but I am open to opportunities if you would like for me to be your consultant. And so I'm just going to briefly go over constructing the blueprint, and that would be prevention strategies, screening and symptoms, and complete cancer care treatment. So the reason why it's relevant to look at cancer care is this, and warning to all of those who feel uncomfortable or anything like that, I should say it here, who feel uncomfortable with any graphic images or extreme diseases. But what I'm showing you here are all cancers that are treated electively. These are not emergencies, but these are surgeries that do need to be done in order to debulk or restore function and that type of thing. A lot of people think, well, if I get this cancer diagnosis, then forget it. You know, this is just how I'll die. But then you end up in the emergency department with bowel obstructions, with problems with vision, difficulty eating, and things like that. So it really is better to go after getting your cancer treated. What I'm showing here is something called carcinomatosis. That's all these white spots in the pink soft tissue. And that just means that it's something that we can't remove surgically, but we can give you treatment with medication and some other therapies. So we want to not delay cancer care because we don't want cancer to be unresectable, and we want to treat. In fact, there's a group out of the UK that put together a study that looked at 24 cancer types, and they estimated the number of excess deaths associated with the pandemic. And what they found is that we would have 33,890 excess cancer deaths in the United States. What are the causes? Well, cancer itself, COVID-19, and or having a comorbidity. So these are also some risk factors for excess cancer deaths. And I have seen anecdotally in my practice, some patients that have presented because they were afraid to go to their doctor, they were afraid of getting COVID, but now they have advanced disease. and we can't really treat it the way we could have had they come in at the beginning. So what's the plan? What can we do about this? Well, I think the first part is screening and recognizing symptoms. I just heard a story of a woman who had some abdominal pain, nausea, and vomiting, and she thought about staying home, but she decided to activate EMS. She went in, she had a CT scan, and she had some obstructing renal stones, but she also had a renal cell tumor. If she had not gone in for those symptoms and just let it go by, she may never have known, or she may not have known soon enough. Now that she knows, it's at a stage where it can be removed. So after it's removed, we can do staging. And then from there, we can make decisions about surgery and using the NCCN guidelines to determine the other treatments. And I also think having a second opinion is very important when you're treating cancer. So let's talk about screening. We screen for breast, colon, prostate, and also for lung cancer in specific populations. And I say for those in the African-American populations and also Latino populations, begin your discussions with your physician at age 40. That's a little bit younger than we mostly think about, but what we're learning is these ethnic groups do appear to develop cancers at an earlier age. And so if we begin these discussions with our primary care physicians at an earlier time, we may have some more time to start to address that. So this is a little bit of a timeline that shows the times that you should begin discussing different types of cancers. Of course, young women start discussing cervical cancer screening at age 21 with pap smears and the like. At age 40, they begin speaking about breast cancer. At 45, that's when we should really begin our screening for colon cancer, but I think those conversations should begin at age 40. At 50, breast cancer screening, if you haven't already started. So even this timeline says maybe think about that starting a little bit earlier. And then at 55, prostate cancer screening, although I really feel that men of color should begin that at a much earlier age. And then there is a screening protocol for those who are heavy smokers and have been smoking for a certain period of time. You are eligible for a covered CT scan of the chest to look for lung cancer. Okay, so that's a little bit about the prevention aspect. I want to go on with some information that is just intended to be thought-provoking and focused on prevention and also for self-care, so that there's some things that you can do to maybe prevent cancer or other illnesses. And my acronym that I use with my patients is honor yourself. So I'll talk about that a little bit. Strategy 2 is to get to know your body, know how it functions. Strategy 3, get with a primary care physician that you trust, not someone that you have a difficult relationship with, someone that you feel doesn't listen to you. There's a lot of people out there that can help you find somebody that you can form a partnership with, and then together you can take care of you. And then you want to eliminate obesity and comorbidities. I actually have a patient, I also do obesity medicine, but I needed to do surgery on her. So we worked on her weight loss. She lost 10% of her body weight. We were able to eliminate her diabetes, her hypertension, her hyperlipidemia. We strengthened her tissues. She had a very successful surgery. So it can be done. And just FYI, these are the cancer surgeries that I do: sarcomas, melanomas, breast, colon, and gastric cancer. All right. So I'm going to go through this very quickly. If you guys want to spend some more time on this later, we can, but this is what I call honor yourself. And this is what you can do to empower yourself to take care of yourself. So basically, hydration is the H. And, there's a certain amount that's recommended by the American Cancer Society. You want to make sure that you are not urinating through the night, and you can get it through foods and other liquids. Organ detoxification, there's a way to do it through enzymes that come from certain vegetables or fish, but you can also do it through certain spices, resveratrol, artichokes, other vegetables. You want to take care of your kidneys and your liver. Nutrition, avoiding processed foods. I really emphasize 4 to 5 servings of vegetables every single day. And I think some of us physicians are not able to get that, but that should really be our goal. And of course, limiting sugar and high fiber is very important, and also getting adequate protein. These are some cancer fighting foods. Again, I'm going to go through it quickly. If you guys want to loop back, we can. Exercise is key. That's why I'm not on camera, because I had to do my workout today and I still have on my workout clothes and everything. but you need to carve out time for yourself all the time. And even if it's at the expense of something that somebody else wants you to do. And these are some of the reasons why exercise in terms of reducing cancer risk. You can reduce your esophageal cancer risk as high as 42%, but you can also decrease breast cancer risk, colon cancer, head and neck cancers, endometrial cancer, almost all these cancer types. So this is really amazing what exercise can do. Rest is something that's really underrated. Getting that 6 to 8 hours per night of sleep really helps to recharge the physiology. It restores tissues, nerves, things like that. Dr. Maxey, you were looking for a way to cut your last nerve. Deprive yourself of sleep. Sooner or later, it's going to snap. Okay, so let's not do that. Let's keep that nerve intact. Okay, but you want to practice good sleep hygiene and get enough rest, because too much sleep and not enough sleep are associated with increased mortality. That's kind of a surprise. Relationships are very important. We don't really talk about that enough, but I really like this book, The 4 Agreements, but you can find something similar that may help you. But the 4 tenets are: be impeccable with your word, don't take anything personally, don't make assumptions, and always do your best. So I invite you to read that book or books like it to really help you with what you're trying to do. I've had a lot of patients come to me and say, well, you know, what can I do about my environment, my household, in order to create an environment where it's not contributing to my cancer? Well, you want to have products around you, whether it's through your body care products, laundry, household cleaning, that don't contribute to your cancer care. So I do, work with them on finding those products, things that are not toxic, that are natural, that will help with your environment, and also the vitamins that you take in. So here's a summary of that acronym: honor yourself. And here's the part about knowing your whole self. So you want to familiarize, recognize, and then you want to nurture those things about your whole self. And then in terms of the impact of health practices, it really is based on the flight or flight response. And we know that when you're in the fight response or flight, you are in a situation where you have a lot of stress on your physiology. You have increased stimulation of things like cortisol and adrenaline. And those are things that really shut down your immune system. It shuts down your normal functioning. It also is hard on your physiology. So you want to stay in that whole rest and digest syndrome so that you're nice and comfortable. And so you want that healthful living, you want illness prevention and cancer screening. So again, the blueprint is the 4 cancer prevention strategies. You want to begin cancer screening at the appropriate age, and you want to complete all 4 steps. And you also want to get to know your whole self. So this is just the flyer that's associated with the meeting that's coming up on the 24th. This shows the person to RSVP to, if you can see it on the screen. If not, contact Don Howard. So I went through this very quickly. If you guys want to go through any of the slides in more detail, I'm happy to do so, but I just didn't know how much time you wanted to give me. So that is my message for today, and I look forward to questions.
Well, thank you very much, Dr. Cutter. I really appreciate that, and that was brilliant. So I've asked, since Dr. Walks is a psychiatrist and I'm a nephrologist and Dr. Neighbor-Stephens is a pediatrician, I asked Dr. Hines to step up front and help us question you. All of us will jump in. But Dr. Hines, would you start our discussion?
Sure. One of the things that I think is a good place to also talk about with people we're talking about in the context of screening is, what would you say are some of the benefits to preventative health screenings just in general, or cancer screenings, or getting your recommended screenings in general?
I think as many face-to-face opportunities that you can get with a healthcare professional really puts you in the situation of having a disease state detected or some type of condition detected. A lot of people have things that are kind of brewing, right? And, if you're one of those people that's kind of stoic and you're not, trying to get into your doctor or what have you, then you're just going to overlook a bunch of symptoms because you don't really want to give in to that. But if you're getting your screenings, people are going to ask you questions. And not only is it going to show you what's going on with that particular screening test, but it's also going to help you to enter into some better health practices.
Do you find that people are still coming with the mentality of I want to be screened for everything, right? That space that says, oh, I'm going and I want to make sure I have nothing, check me for everything, the everything test. I used to find in practice, lots of times people would come and have this expectation that there's some magical, Star Trek level screen that will do a body scan and tell you everything that you could possibly have.
You know what? Sometimes I wish that would happen, but being a specialist, people are usually referred to me and they've already kind of gone through that litmus test and something has usually been detected. Sometimes I take call and I see people in the emergency department and then, you try to work them up. What I get sometimes, which, is kind of personally frustrating, but I realize, there's patient autonomy. There's some people, you give them their diagnosis, they don't want to believe it. They think that they're going to be fine. They don't have cancer. I have a woman right now, she's about 72. She's got an ampullary cholangiocarcinoma, and that means that she has a cancer of her biliary tract, and it's on the bile duct that connects the liver and the small bowel. It is biopsy proven, which almost never happens. We can never get the biopsy to turn out. It's on imaging, and we saw it on endoscopy. She refuses to cooperate with her preoperative workup. She doesn't think she has cancer. We can't even, so we're not going to operate on her because she's just not checked in. So I would like to see people more interested in wanting to know and to following through on the recommendations.
So Dr. Cutter, let me jump in because that is such an important point. And it wasn't even the question that I had, but I really want to follow up on what you just said.
Okay.
It is from a mental health perspective, it's a big deal to get the big C diagnosis. And I know that we've all had folks who don't want to admit that they have anything going on. But when you have someone who clearly can be helped if you can get them to take something seriously, is there a process that you go through? Is there a referral that you make to a mental health person or to a general practice person, or do you take it back to their primary care doc? How do you manage that? It's got to be frustrating for you when I can help you if you just let me. How do you manage that?
I think I'm fortunate because that doesn't happen to me very often. I would say 9.9, out of every 10 patients, they follow through and they take it seriously. I'm kind of a tough physician. I give a lot of tough love because I'm very interested and I want people to do well. And I'm tough because I want people to take responsibility for themselves and what they do. But when I do encounter someone like that, I really try to break down the explanation in a way that I'm certain they can understand. So if I need a translator, I get a translator. I always have handouts. So this particular patient I spoke with, I used the translation system twice. It's tablet based. I gave her 2 handouts on her condition. I spoke with a loved one and her at the same time. I even enlisted a physician, another specialist who speaks her language to talk with her. She has made a decision in her mind where she is, and we have to respect patient autonomy. I can't treat her like a child if she's got all the information. She says she understands, but she doesn't want to act on it. So I think that, one thing about being a cancer specialist is we also really learn about patient autonomy. And with my patients, if I explain to them what's going on and they say, you know what, I don't want surgery, which that doesn't happen very often, or I don't want chemotherapy. I really go through with them. Okay, why don't you want chemotherapy? Why don't you want surgery? What do you think is going to happen? And then if we can get to a better understanding and they have a misconception, that's great. But if they are just adamant and this is their choice, I say, well, then what can we do to make this process work for you?
Wow.
Yeah. Dr. Barbara, can you hear us? Dr. Neighbors-Stevens?
She's not on mute, but we know how the cellular telephone gods are sometimes unkind. Can I just follow up again?
Sure.
Dr. Cutter, one of the slides that you had And thank you for going through the slides expeditiously. Some of them I didn't get a chance to read the whole thing, so we can have Dr. Maxey negotiate for us being able to get another look at them at some point. But one of them you had when you were outlining the times for people to begin certain screenings, and I really appreciate the comment about African-American men, men of color, pushing that prostate screening to earlier, because I had a very good friend who actually died from prostate cancer at 42. So he was too young to even begin screening by anybody's definition. But
Right.
I know other folks that have been younger than the 55 that have Black men that have had prostate cancer diagnosis. My
Right.
question though was, at 65, have a discussion about when to stop cancer screening. That one caught my attention because I know people can be a really young 65 and can even be a young 85, but can be a not so young 45. So can you go through that discussion about when to stop screening?
I love that question because that is really something that we debate in oncology now. And I am of the belief, we have so many people who are living to 90, 100. I was just in the hospital yesterday. I operated on an 85-year-old. The guy after me in the OR operated on a 104-year-old. Why in the world do we stop screening on people who are in decent health? So I don't necessarily agree with that stop screening guideline, but that's what the published guideline is. But I don't agree with it. I think we should still screen. People are living longer. 80 is not so old. I mean, it used to, we used to think 65 was old. Remember you were a little kid and you're like, 65, holy cow, that's as old as it ever. Now it's like 65 is a spring chicken. I was just walking with a sorority sister of mine. She's 65. She looks fantastic. So I don't agree with that recommendation. I think we should continue to screen, but that is not a published recommendation.
Let's talk about that prostate cancer for a moment. I read some statistics earlier that if you have a first-degree relative, father, uncle, brother, with prostate cancer, that multiplies your odds of having the same thing. And in those cases, they recommended screening even earlier, even in your late 20s and 30s, because you're more likely to get it. And we also know that the more aggressive the rise in PSA that you have, that is a telling sign of what your ultimate therapy would be. Could you comment on some of those issues?
Those are some fantastic points as well. And one thing has always baffled me is, we start cervical cancer screening at 21 in women, but we start, prostate cancer screening so much later in men. Why is that? And we know that the vaginal canal and the cervix really gets, a lot more exposure to things because it's a mucosal surface, right? So that's one of the reasons why. But I think that it is prudent for men to get, some of those early exams. It may seem uncomfortable, but my goodness, it only lasts about a minute and then you're done for a year, So I have met relatively young men, 42, who have had to get total prostatectomies and have thereafter have some type of erectile dysfunction. But that's because the disease was discovered later. So if they had started screening at an earlier age, it may have been detected sooner and treated so that they wouldn't have had to have a radical prostatectomy. So to me, I think it's better to know sooner rather than later. And I agree with you, if somebody has a first-degree relative that is affected by that type of cancer, they should definitely have those conversations earlier, even if you have to cajole your physician, hey, just give me a quick prostate exam. I just want to know. So those would be my thoughts in terms of getting that earlier screening in terms of prostate health. Oh, and you mentioned PSA. PSA has been a little bit controversial. We know that it's one of those tumor markers, and in general, our tumor markers are not 100% diagnostic. But the way that we use tumor markers is if you have a diagnosed cancer and you have an elevated tumor marker, we can use that tumor marker to track the success of your treatment. So there's some people that do have a cancer, but their tumor marker is not elevated. So we can't rely on it in those people, but in the other people who do have that elevation at diagnosis, that is where it's useful. So PSA is a little bit similar, but we know once it gets to a certain level, it's definitely positive. So it's important to track the trend. If it's going up, then an evaluation is definitely indicated.
So I'm going to let Dr. Hines take the next, but there's an adage that I heard that a large percentage of colon and rectal cancers are no more than a finger's length from the orifice of the rectum. And a lot can be detected. And I had a recent experience with a 55-year-old pastor who was a bit obese, and he ended up with a fulminating rectal cancer, which could have been discovered earlier. And many men resist having a rectal exam, and even a lot more resist having a colonoscopy. So that's of concern.
I agree. That's a big concern. You know, I had a woman recently, she was about 52, and I was consulted on her. She came to the emergency department with abdominal distension and discomfort, and she had been back and forth to the emergency department for months, and she had been to her doctor for years. And the situation was, her doctor said, you don't need a colonoscopy. You know, she was a woman of color. You don't need a colonoscopy. We'll just do the test, you know, the blood test or whatever. So they have been testing her every year for colon cancer, and it's all been negative. But then I got consulted because she has widely metastatic colon cancer. It is a large lesion of the right colon. And I did a staging laparoscopy. I put a camera in to take a look. I have never seen this much metastatic disease in my life. It's on every single surface, every organ, it's on the diaphragm, it's everywhere. And she looks good. She's walking, talking, her belly is just a little bit full. But, you know, that's what happens when we take shortcuts with screening. So I know everybody wants to do a little blood test or, you know, that type of thing. But I would say, you know, if you really want to go in that direction, get your first screening colonoscopy to see if you have a propensity for polyps. If you have absolutely no polyps, then if you qualify for that other test, maybe you could consider that. But I really am a proponent of colonoscopies more so than, you know, any blood test or stool test. What do the rest of you think about that, Cologuard or other testing? I mean, I'm not criticizing anything, but what do you guys think about colonoscopy versus some of the other tests?
So for me, what I'll say is, I think one of the things, and there's a couple of questions in the chat that I want to get to too, but that is also going to get to this point. It gets to be about, in my opinion, discussion, right? So if we can all agree that colonoscopy is the gold standard, the best way to look for colonoscopy, but it's not the only way. So if the choice, if I'm talking to a patient who is truly screening, because what I also heard in your story too is screening is for people who have no symptoms, right? So if the answer is we can use a Cologuard, which is basically you get a little stool sample and they send the stool sample to the lab, and then they look for any atypical cells in your stool that might be suggestive of a cancer. If the choices are, I could do that for someone who is truly has no symptoms of anything, right? Versus nothing, then I'll take that, right? If the answer is, because there are other options that are available and have been around for a long time beyond Cologuard, right? Cologuard is and again, that's the one where you send in a little stool sample. That's one of the simplest methods, but it's better than nothing, right? If we're talking, what I heard also in your story though is this person wasn't asymptomatic, right? They had symptoms and should have been pushed in a different encouraged, I'll say, to go in a different direction, probably a lot sooner because now you have symptoms of something. So I think when you're talking about discussions, and then that also goes back to the slide you have about discuss stopping screenings at 65, because there's a question in the chat about, since cancer screenings seem to stop at 65, is Medicare still covering the screening process? And I want to make sure that we go back to say, Dr. Cutter was not saying, and nor is Dr. Walks, that screening should stop at 65. The key word there was discussions. And it's really meant, because screenings are saying, if screenings are designed for before anything has happened, before we are aware that anything has happened, do we want to check to see if we have this in the context of cancer? And you take into account in the discussion, you take into account what other medical problems that you have, what are the other things that are going on. If, for example, you have a set of circumstances where your life expectancy is only 5 years, right, at 65 years old because of other issues that you have going on, screening for colon cancer may not necessarily be the top of your priority list, right? Which is different than if you're talking about somebody who, in these other examples, you're 85, you're in great health, right? And the colon cancer that might take 10 years to affect you, we should still screen, because I expect you to still be alive, walking and doing marathons at 95. So that's where the discussion part is key, because sometimes in the other things that we've said is you have to meet your patients where they are, right? And if the answer is, I'm not willing to go for a mammogram, but I'm willing to do a self-exam, or I'm willing to let you do an exam, doctor, again, all of those things are part of discussion, right? And the acknowledgement that this is the gold standard. But sometimes something is better than nothing, especially when we're talking about true screening. Once you move into someone who has symptoms of something, then it's not exactly screening.
I think Dr. Neighbor Stevens, did you have a comment?
I do. Can you hear me?
Yes, ma'am.
Great. I want to make some comments addressed to our lay audience. The comments that have been made up to this point are all very important and relevant. But I'm a very practical person, and there's some practical facts of life that we need to address in this conversation. The first thing is you have to have a relationship with your physician. If you don't have the relationship with your physician, you're not going to have the conversation. And some of the things, probably one of the biggest barriers to having the relationship-based with your physician is insurance, or the lack thereof. But even if you have insurance, particularly if it's one of the lower cost marketplace products, your choice of provider is very limited and frequently does not even really allow for regular, if any, contact with a physician. Most of those plans tend to steer the patient or the member to a mid-level provider. So we got some access issues that we cannot ignore. The other thing that insurance does, and it is based on the nationally accepted list of preventive tests, sorted out, and I always call this group wrong, but U.S. Preventive Health Task Force. They're the ones who set which tests are to be done and when. And based on that, that's where the decision comes that if you are over 65, certain screenings are no longer necessary. That's where this is coming from. And that's also what is impacting the screening rules with Medicare. So you need to take on I hate to say the fight, but it is a fight. It's your fight. You want to do what you have to do to get what you need. And you, unfortunately, you are more likely than not to run into some significant barriers. I can't tell you how often young Black women, particularly, who have family histories of breast cancer or who don't have family history but find a lump, face quite the battle to convince somebody to order the necessary mammogram if they're younger than 40. And even if they do get it ordered, that doctor or provider has to be willing to fight the battle to get the special permission to get the test done because the person is under the normal age for those tests. And this is true whether we're talking about breast cancer, whether we're talking about prostate cancer, whether we're talking about colon cancer, anything that has a nationally established cutoff or beginning from U.S. Preventive Health Task Force. This is going to create barriers that you will have to fight and overcome. And then finally, I want to say, and this is, and Dr. Clark cut me off if I become inappropriate, but we have a lot of physicians that don't practice good medicine. I cringe every time I hear that someone's heart was examined and they were not undressed. I cringe when I hear that an overweight or obese Black woman goes to the doctor who doesn't even touch her. And these are stories that I hear on a regular basis, and they have tragic outcomes, as you might imagine. So as a community, we have had to fight for everything else. Our health is no different. So first, we need to know what needs to be done for us. And then we have to hold people accountable and do what has to be done to get the care that we need.
I think those are points that are so important, Dr. Neighbors-Stevens. Even though you're in the car, I think those had to be raised. And before we recognize Dr. Jordan, I did see his hand up, but let me just make a comment that a lot of patients don't or can't afford the best insurance, which is usually thought to be PPO, private pay insurance. But they haven't considered that by having that type of insurance, those companies are set up primarily to save the company money. And the doctors that are affiliated with those companies are incentivized not to provide what they consider expensive testing. And for example, the more money they save, that ends up in a year-end bonus. So the fight is fixed from the beginning. So we need to find a way to do that. You know, even with the Obamacare insurance, there was a time when I know I would see a patient do a complete workup and physical and get basically $6 for spending an hour with the patient. So we've got to find a way to get around that or have a better approach to that. Because money does drive a lot of things. And I think that we've got to figure out a way to do that. Dr. Jordan, you had a question or comment?
Yes, and thank you for those comments because that's very important. One of my neighbors who's 97 years old stopped by. He walks 5 miles 5 times a week. He's very healthy. He wanted to know if I would write him a prescription for some Preparation H. I've never examined him. We speak. So I said, well, I'm uncomfortable unless I at least get a look at what you're calling hemorrhoids. And of course, you know, I treat HIV. He didn't have hemorrhoids, he had rectal cancer. So that took a whole different thing. But I think, you know, as our speaker, who is president of the Zoo Society, there should be a marriage. Anyone that we want to have a test that insurances or something is saying no. But those things, there should be a way the Drew Society should work with the county hospital and get it done. I have never not been able to get a test done at Martin Luther King if I wanted it done, period. And I think that should become necessary. Now, it doesn't mean doing mass screenings, but if we really have someone whom we think needs to have a test for something, and their insurance is saying no, as you described earlier, then to me that becomes a way of really referring them for that particular thing to King or to some other county place. But we should not just say no and let it go because of that. You're right. Those insurances are trying to save money. And we don't want to save money at someone's life, at the expense of someone's life.
I
Let
think,
me make it-
can I just jump in here, Dr. Maxey, and
Sure.
comment on the insurance component? As a practicing surgical oncologist, testing is a big part of how we manage patients, right? I need a CT to see, what I'm going to do in surgery. And then when I'm done, I need that. And then, if it's a colon cancer, they need a colonoscopy. I think Dr. Maxey's right. There's a lot of incentive to refuse this testing. So what we're seeing in the community is that patients are getting referred to substandard centers. They're getting the test done, but they're inaccurately read or inaccurately done. So you end up burning a lot of time. Cancer patients don't have time. And that's really what the game is. Same thing, if you can't get a test done in your home institution or what have you, you have to refer somebody to a county hospital. Now we're dealing with time. How do they get in? How do they get the test scheduled? There's a big backlog. So, I think it's important what Dr. Maxey said about really trying to get the best insurance that you possibly can. I think that's one thing you can do. The other thing you can do is build a relationship at county before you have a problem so that if you need to get in, you have a pathway in. It's really hard to get in there cold and you can't wait. So that would be my comment on the insurance question.
Let me make a comment for some of the physicians to respond to. Knowing some of the barriers, and that if you put in a diagnosis that possible colon cancer, possible so-and-so, or I think this, and you don't make a definite referral based upon a diagnosis that you feel is right, you're not getting in. So by physicians having a relationship with the patient, and I'll admit this, even though I'm online, Dr. Walks, you can get me if you want. I may give a diagnosis that may not be verified because that's the only way to get that patient in. And I'll do that if I have to get that patient what I think they need.
Thank you.
So Dr. Maxey, you have to allow me to stop you before you say stuff. It's too late after you say it. Let me make a couple of comments if I can. I want us to remember where Dr. Cutter's presentation started, because Dr. Cutter's presentation started with us being able to do stuff ourselves, with us being able to eat foods that are going to be healthy. Not the very first two slides, because those were scary, but maybe they'll scare you into the third and fourth and fifth slides where Dr. Cutter really rightfully told us about how we can protect ourselves, and also talked about if someone is able to maybe lose 10% of their body weight, if it's appropriate, again, working with your doctor, you can cure a lot of the stuff that you go to the doctor says, hey, your blood pressure is high, here's a pill. As opposed to your blood pressure is high, your blood sugar is a little bit elevated. Can we get you on an exercise program? Can we change your diet? There are some other things, back to Dr. Jordan's point he makes frequently, how we work with our doctor, get a primary care doctor, have a relationship. So maybe you get into those first few slides as opposed to toward the end. And now our conversation is about how do we get a test run? Let me say one thing hasn't been brought up yet. I love the part of Dr. Cutter's background that Dr. Maxey mentioned about the business part of it. And I know Dr. Hines has an MBA. All you business people, I used to be a corporate vice president, and one of the things I worked on was healthcare system design. And we worked in multiple states designing public pay private designed and private run healthcare delivery systems. And you know when doctors aren't incentivized to not do any tests? When you design a system so the doctors and the providers are on the hook when people get sicker. If you save money by just denying tests, that's not the best system that we can design to take care of people. The system we can design to take care of people, and Dr. Steiner put in the chat, universal healthcare, which is why I love Dr. Steiner so much. There's something about us looking comprehensively at the healthcare systems we design. We've talked on this program before about talking to the LA County Board of Supervisors about health-related issues. If we keep looking at one part of the system, we are going to fight inefficiently. We have to hit people in the money. That I like to say that. Punch them in the money. If we hit people in the money, we get their attention, and there are ways to look at healthcare system design and put structures in place that incentivize people to keep us healthy.
Dr. Walsh.
The next 3 hours of my speech are going to happen after we get off camera, but that's the first part.
Dr. Walsh, Mr. Dorsey is an insurance executive, and he wanted to make a comment relevant to what we were discussing. Can we unmute him, Simon? Mr. Dorsey? Okay.
While we're waiting for Mr. Dorsey, I will also say that in the insurance, to your point, healthcare is the healthcare system is huge beyond your imagination and extremely complex. But one of the things that is overall changing is what's called, if we're talking about dollars, is what's called value-based payment, which is basically saying providers and the people who, providers themselves and the insurance companies are going to be paid better when their members, when their patients reach their healthcare goals, right? So you'll get better payment for controlled diabetes, better payment for controlled blood pressure. There is also now a strong movement for increased emphasis on the social determinants of health and finding ways to quantify and identify those factors, because while we're all clear that that's been noted as probably one of the biggest factors that impacts health outcomes for some time, the entities that do data are just trying to figure that out. So in my current life, while I'm not seeing patients, some of you all have asked about, whether or not I see patients. I don't. What I do now is healthcare analytics. So where I spend my time is churning and figuring out ways to have all that data and what people are doing with that data to talk about healthcare outcomes, population health management. And that also ends up being, you change population health one person at a time. But to your point about where this conversation started, one of the things that I also think that we might want to go back to is, and especially in the Black community, we're not going for the preventative care, right? We're not going to the doctor in the first place, because we could have a whole conversation about barriers once we've been and we've done all the things that we're supposed to. But the reality is a good number of us aren't going. It's why we have initiatives like Take Your Loved One to the Doctor Day, because we're not going in the first place. And I just want to, I really liked Dr. Cutter's acronym about honoring yourself. There is nothing that I can think of that I plan on keeping for a long time, be it my car, my house, my teeth, my hair, right? That doesn't require some degree of maintenance. If we all sat around acting like my car was going to fix itself, and I'm only going to wait till it's smoking and sputtering before I decide to take it in, when that finally happened, y'all would look at me like I was crazy, because, right, well, you didn't take it to get an oil change, you didn't take it in for the routine maintenance. And many of us are not doing our personal bodies that same level of maintenance, that same level of care and concern that we are giving to, like I said, anything that you want to keep around for a long time. you care for it some way. And some of us some of us are not just doing basic care for ourselves. And while we're talking about prevention, I just want to take 2 minutes to just snag in dentist. Dental care is about more than aesthetics. It is about more than, your pearly whites. But again, something that ideally you want to keep around for a really long time.
Dr. Hines, I had
yes.
a dentist say to me, you should only floss the teeth you want to keep.
Right. It's so true. But many of us, again, we're not going to the dentist. Dental care is about more than just, bad breath, right? It has links to heart disease and overall mortality. So I just wanted, and again, things that we can control. We
Bad
can
habits.
control whether we go, right? Whether we tried, whether we cared.
So thank you, Dr. Hines. Mr. Dorsey is unmuted. Mr. Dorsey, your comments, please. I can see Mr. Dorsey on the screen. I can see he's unmuted.
He's on his phone, which is 225 number, 225-938.
Well, help me, Dr. Maxey, you asked me to stop you before you do stuff. I don't know, you want to give Mr. Dorsey's cell phone number out over the meeting. But I'm looking and I can see Mr. Dorsey is, Mr. Dorsey, please interrupt me. I see another cell phone that has 388 as the last three numbers. I don't think that's it, but I don't hear Mr.
Louisiana
Dorsey.
is 225 area code.
Okay.
Okay.
We can get back to Mr. Dorsey or Mr. Dorsey.
I got
please.
it.
Oh, there he is. Okay.
Praise God.
Praise God all the time.
First of all, I just want to thank Dr. Cutter for her extraordinary presentation. It hit close to home. I lost a very dear friend and a pillar of the community at an age that we thought was much too soon to undiagnosed prostate cancer. One of the things that I have benefited from, and I've seen other people benefit from, is organizations such as TPAs that give money back or share savings with the physicians to keep people out of the hospital, and it gives them extra incentive to be a bird dog about finding exactly what's wrong with you. If I didn't say it before, I'm saying it now. Understand insurance is a business. They're in business to collect premiums, not pay claims, okay? And in the times that we're living in right now, we have to look at our health insurance not as we have to look at it as a necessity and treat it as such, not something exorbitant. And I'm saying that to say, if you need to reduce the premiums on your health insurance and you are in reasonable health, first thing to do is look at increasing your deductible to the maximum and going into the details of that particular plan to see how many free visits you get to your physician. Because in those free visits, even though you have reduced your premiums to such that, you don't want to have to pay a $10,000 deductible every time you go to see the doctor. But if that plan comes with automatic annual or biannual visits, you get around it. The only thing that you're going to be using your health insurance for at that time is a catastrophic situation where you need a card in your hand to save your life, because they're not going to treat you in the hospital like they treated Denzel Washington if you draw a gun to get service. Ain't gonna happen. A few years ago, I heard Harry Belafonte talking about early diagnosis. And he was, a big proponent, or he is a big proponent. He raised his index finger and middle finger, and he made the statement, after many annual exams for prostate, no doctor ever asked him for a date at the end of the exam. So I just want people to think about that. There are ways to, you don't have to say no insurance if I can't satisfy the premiums that they put on the screen. You got to understand, if you go on Obamacare, they might put up 10 or 12, but they may be 30 or 40 different options if you go in and dig. So that's my spiel. Thanks again, Dr. Cutter. Appreciate you.
Thank you.
Thank you.
Thank you
So
for
there-
making the point.
So
ahead,
there-
Dr.
thank you, Mr. Dorsey, so much. There's a question in the chat, and it refers to moles. I know, Dr. Cutter, you one of the slides you showed early was a slide about what can happen if things aren't looked at early. But I guess I will take that question about moles and I will say, I don't know what to look for when I look for a mole. All I know is to go see somebody who knows what to look for. Go see a dermatologist, go see somebody who's an expert in that, because moles look so different on different people. So can you just make a general comment about if your cousin walks up and says, "Oh girl, that's a normal mole. I got one just like that." Is that okay?
So this is, one of my specialty areas, which is melanoma, which is a skin cancer. And it is related to things that look like moles or innocuous things at the beginning. And, we need to differentiate that between squamous cell carcinoma, basal cell carcinoma, which are the other skin cancers. Each of those is managed differently. The reason why melanoma comes to the surgeon, the surgical oncologist, and not the dermatologist, I'm going to repeat, not the dermatologist, is you have to get wider margins and you need to do a lymph node dissection. So what the dermatologists do is they will remove those other lesions, basal cell, squamous cell, and all those things, anything that looks suspicious. So now the question is, what does suspicious mean? So for somebody who has something on their skin and they're wondering, I want you to also look some other places. I want you to look on your palms, on your soles, under your nails, your nail beds, and on your scalp. People of color tend to develop skin cancers in those areas, these sun-exposed areas. So again, your palms, your soles, your nail beds, and your scalp. And so what is suspicious? Anything that is growing quickly, changing in shape or color, advancing beyond its pre-identified borders, oozing, bleeding, or emitting a substance. These are some of the conditions that make things suspicious. So I've treated people. I had a woman who had these cysts on her scalp for 30 years. And the pandemic started and one of them began to grow. Well, she didn't think anything of it because she's had these cysts for 30 years. If I could show you a picture of it, I would, but it really was the size of another head on the back of her head. And her family didn't see it because she was wearing a turban and they thought her hair had grown and that she had just wrapped it up under the turban. She had a giant cancer and it's a certain type of malignant change of a benign cyst. So that can happen too. So I'm not saying these things to make people paranoid. I just want you to be aware if something seems odd, it probably is. If things are changing or changing quickly, you should have somebody look at it. If somebody tells you it's fine, but you don't feel comfortable, ask someone else.
Thank you.
Because I've also had patients who have gone, I had a woman who had a melanoma on the ball of her foot. She had it removed. I don't know who did it. And they reconstructed it. That's so nice. And then a year later, she goes to her primary care doctor saying this isn't right. She tried to go back to that original surgeon. They wouldn't see her. Okay. It took her 3 more months to get to me. She's got full-blown melanoma in her thigh, in her groin. She had it in her brain. Now it's on her abdominal wall. Whereas if we had seen her, 6 months after that initial treatment, I could have helped to prevent that and gotten her, referred. So things that change, things that don't look right, ask for help.
Would you comment on, I heard someone say that they use the opportunity to take a shower every morning to self-examine their body to see if anything new has come up, even find out they got numbness on their feet, moles. What do you say to something like that?
I just love that. And that was actually part of my prevention talk that, one of the slides that I just breezed through, but that's getting to know your whole self. When you take your shower in the morning, I mean, if you do it every day, you may not notice things, but if you kind of, take a glance every day, but maybe once a week or once a month, you really do a full exam, take a look at your skin when you wash your hair, or if you get your hair done. I had a 30-year-old who had his hair cut by the barber, and he had a melanoma behind his ear. And the barber said, you really need to get this checked out. And he was like, oh, I'm 29, I'm fine. It took him another year to get it checked out. He had a huge melanoma behind his ear. He is missing now about 5 centimeters circular area of his scalp, courtesy of me, to clear his margins, so that he doesn't have to worry about melanoma anymore. So really getting that full exam, enlist your partner, either your, a friend or your spouse or your significant other to look at your back, and to look at areas that you can't get to, and your barber, your hairstylist. And the final thing I'll say about the feet, after a certain age, I wouldn't let anybody come anywhere near me with a sharp instrument. I'm just saying, no clipping of nails or things like that. Let them file them down, but just be careful of sharp things, around your feet.
Excellent, excellent. We're
Can I
coming
just-
close. Go ahead, doctor.
Can I just extrapolate on that same point though? About if you see something changing, get it checked out. Not all of the changes are going to happen on the outside of your body. Some things are going to change and they won't be visible to see. And you should still, unexplained fatigue, right? Like strange pains, unexplained headaches, swelling where things shouldn't swell. Like there are I think Dr. Cutter's point about if something's changing and you don't have a real clear reason why, get it checked out. You don't have to wait till it keeps you from going to work, right? Until it's so bad that I can't keep going. And everything isn't just because I'm getting older, right? I think that's another thing that people do. Like things will be changing and they will notice things happening differently in their body and will just assume, well, maybe it's just because I'm getting older. If your weight's changing, even if it's for the better, like, oh, I'm losing weight and you haven't done anything to earn that weight loss, it may not be a good thing. So I just wanted to point out that not all things of concern are on the outside. Some of the things are happening on the inside, including some of the things that you may be thinking in your mental health space. Again, changes. If they're there and you don't know why they're there, get it checked out.
Excellent.
So good. So as we move toward the end, one of the things that Dr. Cutter started with was preventative medicine and eating. I wonder if you could just review those things and explain just a little bit why exercise helps you avoid certain types of cancer.
Okay, let me get back to that. I kind of moved on with all my little fooling around over here, the things I've been doing. But yeah, let's get back to that. That's an important topic to look at in terms of, why is exercise important? Why are any of these things important? Why should we bother, to do any of this? Because, let's face it, time is short and, it takes some energy to do these things. So why even get into it? Well, I think somebody made the point earlier about a car and what it takes to maintain a car and things like that. And some of us really take better care of our cars than we do ourselves, right? We spend all this time, really taking our car in, getting it washed and doing all of these things. And then we just kind of throw ourselves in the shower, dry off quickly and run out the door. So, what hydration does is it really facilitates the body being able to do normal functions. So you need water to survive. And if you don't have enough water, you get things like renal stones. You know, it can also contribute to gallstones. It can affect your digestion.
How much
There's a lot
water
of things that can do.
per day? How much water per day?
So American Cancer Society recommends 9 cups for women, 13 cups for men, but I am really big into your body weight in kilograms, you know, getting something close to that in ounces. So let's say that you weigh 70 kilograms. So of course you got to do the metric system, but let's say that's what you weigh. Then you want to get, you know, something close to that, 60 ounces, that type of thing. What I tell people to do is keep, you know, get a bottle of water or get your water bottle, fill it up at night. When you wake up in the morning, the first thing you do is chug that nice room temperature water. You go on with your morning, have another set of that either midday or when you get home, so that you're not drinking, you know, an hour before bed. And so you have to wake up in the middle of the night and urinate. So that's a big deal. You can also get what, go ahead.
Let me make a comment. Just insensitive water loss as a nephrologist per day is 1,500 milliliters per day, or 1.5 liters a day you lose, not even counting sweating, just from respirations and insensible skin loss. So you have to replace water, even if you're not working out and exercise, you lose it.
That's a good point. And the other way that we lose it is with coffee. You know, for every cup of coffee, you need to get, you know, 2 glasses of water going. And same thing with alcohol. You need to have a couple of glasses of water after that. These are diuretics, and you will lose water from that. Organ detoxification is important because this is how the body processes toxins. This is how it helps to get rid of the cancer cells or, you know, other deleterious things that we take in. So we need to really prepare these organs to be able to perform these functions. And the foods that I have listed here are actually pretty good. You know, you have a little broccoli and some salmon and with garlic on it and turmeric on some other part and a glass of wine. It's a done deal. You've already detoxified your organs, so it's not so hard to do. I think nutrition is one of the hardest things for us to do in this country. We've gotten away from vegetables, and real vegetables have color. And I don't think that potatoes and corn count because they're starchy and they don't really provide as much nutrition. But other colorful vegetables will give you what you need. So 4 to 5 servings, that low in sugar. You know, you can have sugar with moderation, but I also think we should learn to drink beverages without sweeteners. And that can be hard to do. My Asian friends in New York, when I was training there, they taught me how to drink tea without sugar. I was like pouring the sugar in the tea when we would go out to eat. And they said, "What are you doing?" And I said, "I'm American. This is all I know." So, but I did learn. These are some good cancer fighting foods, but what this means is these support your immune system. So they're really good for disease fighting overall. And some good anti-cancer superfruits, same thing. Some of these are exotic, but some of them are as simple as an apple, you know, with the skin on it. You know, you want that fiber. And fiber is another big thing in terms of diet. Exercise, it really helps, you know, just in terms of reducing insulin. It also moderates growth factors, hormones. It improves the immune function. A really important thing is it's a mood stabilizer. Are you feeling stressed out? Are you sad? Are you upset with somebody? Take a walk. Go do Pilates. You know, go play some tennis. Do something physical. You would be surprised at how much calmer you feel, how much a better outlook you develop. And sometimes you can even develop ideas. I know when I work out, I get so many great ideas and I'm supercharged and ready to talk to Dr. Maxey about some entrepreneurial things. So, you know, I love to work out, and it enhances the brain function. We already talked about this part about exercise, and we already talked about rest and the association with increased mortality. So the good thing to do is the bed should be reserved for intimacy and sleep. There shouldn't be any TVs going on or computers or things like that. Do that in another room. And then when it's time to go to sleep, go into your bedroom. Make sure that the sheets are clean and comfortable. You can spray your linens with something like lavender. That also helps with rest. I used to know someone, he would take a shower every night. He was funny. He would take a shower every day. He was a big burly guy, but he'd take a shower every night with the lavender scented bath gel, put on his workout clothes, go to bed. And he said he would sleep like a baby, wake up at 4:30 every day so he could go work out before work. Like that was his routine. So I think that's impressive. And then, you know, I talked about the relationships. One thing I really want to focus on here is not to take things personally. You know, a lot of things that people say, and this is item number 2, a lot of people, things that people say and do are really a reflection of them and what they think about themselves. It is not really what they're thinking about you, but they are reflecting who they are as a person. So don't take what people say and do personally and allow it to be their problem. And also don't make assumptions. Have the courage to ask questions, express yourself, communicate clearly to avoid misunderstandings. All of those things are important. And then the environment, you know, what you put on your body, your hair, your sheets, and all of those things. So that's kind of the preventive prescription, if you will, in detail and why that's important.
Well, this has been
That's great.
outstanding, Dr. Cutter. This has been so good. So Dr. Hines and Dr. Walks and Dr. Neighbors-Stevens, we're almost at the end. Do we have any last words or anything we need to talk about in the chat before we enjoy the rest of our Sunday?
There's one in the chat that I'd like to highlight, and it says, and it's commenting on regarding how we said earlier that not all doctors are good and not all, you know, truly care about our health. And it says some Black people don't want to go to the doctor when they know others, hold on, it just moved. When they know others who have gone to the doctor and had poor experiences, or they've had poor experiences themselves. And it says people have to be willing to advocate for themselves, but people don't feel comfortable doing that without having some knowledge to fight with. How can we gain that knowledge without going to medical school to fight for ourselves? And
May I answer that question?
Go for it.
I have to tell everybody, now, you know, I am a surgeon, right? And I'm not only a general surgeon, I'm a specialist. So I've had 9 years of surgical training. Do you know that I experience health disparities from my primary care physician? They would not take my complaint seriously. And I complained about this thing, I think, for a couple of years, and I ended up seeing somebody else who got me the study I needed. And then I had, you know, I got the treatment that I needed for that condition. So even people with a medical background have this experience. It's not just limited to people who are non-medical people, but I knew it wasn't right and I didn't give up and I got the treatment I wanted. So what I would say to that person is, if you are finding that somebody is not communicating well with you, you can always find another physician, okay? And it doesn't mean that they have to agree with you. You just want somebody who advocates for you, okay? And who's going to tell you the truth and who has your best interests at heart. So that's how I would respond to that.
Excellent.
Great. Yeah.
My answer is watch the Black Health Trust. And I invite all of the people that look to send us some concerns you have, questions you have, topics we need to cover. That would be very good. Dr. Hines and Dr. Walsh and Dr. Neighbors-Stevens, let's have final comments.
I would just say that one of the things that came out that from Dr. Cutter's slide about the 4 agreements about don't let other people's, you know, things become your things. Self-advocacy doesn't necessarily mean that you're making decisions from a completely informed space, right? We make decisions all the time in areas where we don't necessarily have expertise. I'm dealing with that personally now, but to Dr. Cutter's point, if someone, we've mentioned earlier about have a relationship with your primary care physician. And if you don't have a primary care physician, now's a good time to get one so that then you can establish that relationship and find somebody who can be that person that has expertise, because we all can't know everything. I certainly don't. Like, I'm making decisions right now that are important decisions that aren't in my expertise area. We've all had a bad experience with something. I've had a bad haircut. That doesn't mean I never went to the beauty salon again, right? You pick somebody new. So establish a relationship with the primary care provider who's willing to hear what's important to you and your values. And the other thing I would also say, because we talked about this a little bit about insurance, is if there are uninsured, there are ways for through like county health departments and things like that to get age appropriate screenings, breast cancer screenings, colonoscopies, even without insurance. So insurance, again, does not have to be a barrier to you getting the care that you need.
Very good. Dr. Walks?
I don't know. Do we have Dr. Neighbor Stevens still?
Can you hear me?
Yes, we can.
Go ahead.
I was going down the same path as Dr. Hines about the uninsured. Not only do you have certain offerings at your health department, but you also have federally qualified health centers in the cities, and you have rural health centers in rural communities. And then for those who live in Nashville, Atlanta, DC, and LA, you have 4 Black medical schools that you can go and seek the assistance that you need. And the other point about advocacy isn't knowing everything. Advocacy is demanding up to the point, seeking up to the point of demanding that your concerns be addressed. And yes, I thought, and I think maybe that question in the chat is a check for us at Black Health Trust. What Black Health Trust has been attempting to do every single week is to give you the information that you need to advocate for yourself. And so if we haven't communicated effectively, that's on us, and we will continue to work on it, because that's what we're all about. We are trying to give you the information that you need so that you can get what you need. That's what we're all about. The final point I would like to make, though, although this was about health maintenance, I don't want to forget COVID. And I wanted to make the point that, again, as I say all the time, use common sense. I am hearing statements being made by people who should know better, like surgeon generals and heads of agencies and governors, declaring that vaccines aren't necessary for healthy children, that masks are no longer needed, you can put them in the drawer. Some even going so far as to say that the pandemic is over. Well, let me just say, I heard on the news yesterday, sections of China are being shut back down because they're having overwhelming numbers of cases again. They did not say which strain it is that they're having the issues with, but they're going back into lockdown because of overwhelming numbers of cases. So use common sense and listen to the news and try to stay abreast. Don't be victim to disinformation.
Well, thank you. And to your point, President Obama just tested positive for COVID. Dr. Walks?
Thank you, Dr. Maxey. Thank you so much, Dr. Cutter. I appreciate your personal sharing that, hey, my exercise is what I was doing, so my camera's going to be off today. I think it's important for us to prioritize our exercise to the point that we're going to get it in. I think that we talked last week a little bit about prevention and had a very good talk from Dr. Relaford. Today we've talked about it. It is so frustrating when there are all of these things that we can take care of that we don't. Dr. Hines brought in dental care and how important that is. If we can really understand about the maintenance of our health and how important it is, it is hard to get a healthy 17-year-old to think about if you don't take care of this and take care of that, one day you're going to be 37 and 57, hopefully 77 and 97. But maintenance of health matters so much. And I think it's incumbent upon all of us, every single one of us, physicians, laypersons, whatever it is, to reach out to young people and to help instill in them the importance of managing the things that matter. We're happy to talk to young people about managing their finances and, plan for retirement when you're 18, begin planning for it. We should have them begin planning for being less young when they're 18 or 20 or even younger, so that we can have healthy folks. And then the last thing that I'll say, because of my own experience across my career, understand how things are working around you. Understand when the federal government or the local government is doing something about a system with which you're going to impact. As I said before, I've been involved in designing these systems at a statewide level in multiple states across the country. And people don't know until they show up at the doctor's office and bad things happen. The doctors can't do something because the system doesn't allow them to. So be active. Look at who's running for judge in your community. Look at who's running for county executive, for mayor, for board of supervisors. Understand that these people can make rules that can impact access for all of us. And then, I'm sorry, that was my last thing. My really last thing is this. We also talked about churches last week, and it wasn't all complimentary because nothing is always consistently complimentary. I wanted to point out that the church I attend next week, we're having a big to-do that we've been advertising the last several weeks about mental health, and a big to-do that we've been advertising for several weeks about diabetes prevention and diabetes care. And I think if your church or your social organization isn't looking at things that impact your health and the health of your community, ask the pastor. The pastor is willing to ask you to put something in the collection plate. I think it's fair to ask the pastor about putting something in the church plan that impacts the health of the community. Sorry for any pastors that are mad at me now. Dr. Maxey.
Well, first of all, I'm going to say amen to what you just said. Oftentimes, I've gone to church health screenings, and they put the health screening in the basement around the corner by the last bathroom to show it had no level of importance with them doing the other things. And I think that we do know that part of serving God is taking care of your body that is his gift and his temple. Dr. Cutter, this has been outstanding. And as my president of the chapter that I belong to, I'd love you to say a final word.
Well, thank you very much, Dr. Maxey, for inviting me, and, Dr. Walks and the other moderators for being so generous. And the questions have been terrific. It's important for us, I think, one, to seek help when we need it. But what I really try to reinforce is to take responsibilities for ourselves and the things that we can do. And also to facilitate the health, not only of ourselves, but our loved ones. And health sometimes transcends discussions, disagreements, bad family relationships, all of those things. We really shouldn't let any of that get in the way of promoting good health throughout the family. And one thing I really liked that was said earlier was talking about, really supporting young people. And I think the time to do that is to teach them, when they're 5, what a well-balanced meal is. I think mealtime is not a time to coddle children and give them chicken nuggets. It's a time to give them a well-balanced meal so they know what vegetables look like and how to eat at the table and all those things. I know that's how I was raised, and I really believe in that. We had spinach and broccoli, and I ate all of it because that's what was for dinner. So this whole thing about I don't like vegetables, I don't even understand that. Like, I didn't have a choice. That's what you ate. I think Dr. Maxey can also agree with that. That's how it is in Cincinnati. You eat what you're given and you're appreciative of it, and you go do your chores, right? That's how it is. And you get a job when you're 16, and that's just the rhythm of things. It doesn't matter how much your family earns or anything. Everybody has to be productive. So I think those values is really what's going to help to elevate our community and to bring us forward, and to not have to continue to compare ourselves to other groups in terms of how we're doing, but to set a new standard of health, of wellness, of success and of happiness and of family values. So I just really want to thank you for the opportunity to speak today, and I look forward to the next time.
Well, thank you so much. The Black Health Trust has been on this broadcast for a little bit over 2 years. And part of it is due not only to those of us that serve as moderators, but we have a technical support from Simon Cooper, who has worked almost as a volunteer from the beginning, giving up his football time on Sundays to support us. And we also have another one of my nephews who every Sunday provides us with the skills to put up a flyer. And I'm very important that we recognize them. And going forward, we're going to be asking again for those of you who are able to donate to the Black Health Trust so we can keep this going. We're going to be expanding and be streaming live on certain programs, offering more podcasts and going out. And we all do this at this point. None of us is getting paid, but this comes from the love of our hearts for our communities. But to get goods and services does take some investment of money, and we'd love to have your support. I understand our donate button is working now. And we're working on expanding our website and also certain things that we're going to bring to the table starting as early as next week. So I appreciate you joining us. I appreciate Dr. Walsh, Dr. Neighbor Stevens, Dr. Hines, and of course, Dr. Cutter, and constantly Dr. Jordan for his comments, and the other members of the National Medical Association chip in. Thank you so much. Have a good day, everybody. Exercise and eat correct. I'm going to go eat some spinach, Dr. Walks.
I will not go to Popeyes this afternoon, Dr. Maxey.
Have a good day, everyone. Thank you.
Good night.
Thank you.